Today we will cover mesenteric lymphadenitis or mesenteric adenitis. The mesentery is a fold of membrane that attaches the intestine to the wall around the stomach area and holds it in place. Mesenteric lymphadenitis is swelling of the lymph nodes in the mesentery. Mesenteric adenitis is a syndrome characterized by right lower quadrant pain secondary to an inflammatory condition of the mesenteric lymph nodes. Lymph nodes are a collection of tissue found throughout the body that are responsible for filtering bacteria, virus, and the waste products of the bloodstream. The clinical presentation of sudden onset right lower quadrant abdominal pain is similar to that of appendicitis and has classically been mistaken for it. The etiology of mesenteric adenitis includes several causes of inflammatory response within mesenteric lymph nodes. These include viral infection, bacterial infection, inflammatory bowel disease, or lymphoma. Two common gram-negative bacteria that are known to cause mesenteric adenitis include Yersinia pseudotuberculosis and Yersinia enterocolitis. Other known culprits include Salmonella, E. coli, and Streptococcus. But overall, the most common cause of mesenteric adenitis in pediatrics are viral. But if it is bacteria, Yersinia is the most common one. The etiology can further classify as primary versus secondary. Primary etiology occurs when the lymphadenopathy is the result of an identifiable inflammatory process. When we can't identify the inflammatory process that causes the lymphadenopathy, we call it primary. Whereas secondary mesenteric adenitis occurs secondary to an intra-abdominal inflammatory process with a known source of or etiology of the cause. So primary is a known cause, secondary is there is some abdominal inflammatory process that causes it. Mesenteric adenitis is most commonly present in pediatric and the young adult population. A child under 10 years of age who presents with acute onset right lower quadrant abdominal pain is more likely to have mesenteric adenitis rather than acute appendicitis. Mesenteric adenitis commonly follows recent gastroenteritis or upper respiratory infection because the most common causes are viral. Common symptoms include fever, vomiting, change in bowel habits, periumbilical and or right lower quadrant abdominal pain. Once we evaluate a child, we should have to send CBC, CRP, and the urine analysis. CBC and the CRP are raised, and the urine analysis is to rule out the urinary tract infection as a cause for lymphadenopathy. Abdominal ultrasound is the gold standard for the diagnosis of mesenteric adenitis. Ultrasound that shows enlarged hypoechoic mesenteric lymph nodes and the absence of thickened blind ending tubular structure. That means inflamed appendix is a diagnosis of mesenteric adenitis. So we should have to rule out appendicitis by ultrasound. The current radiological definition defines mesenteric adenitis as at least one abnormally enlarged lymph nodes measuring 8 mm or more in its short axis, or two or more enlarged lymph nodes measuring more than 5 mm. Mesenteric adenitis is self-limiting and it requires no treatment. Hence, the first step in management is to rule out the diagnosis which requires surgical intervention such as appendicitis and intussusception. After establishing the diagnosis of mesenteric adenitis, the treatment is supportive care with IV hydration and pain control. Empiric broad-spectrum antibiotics might be used in moderately to severely ill patients and should cover Yersinia strains, which is the most common causative bacterial mesenteric adenitis. So initial antibiotic selection that covers Yersinia include cotrimoxazole, third generation cephalosporins such as cefixime or ceftriaxone, fluoroquinolones, and aminoglycosides such as gentamicin. Most children with mesenteric lymphadenitis get better in 1 to 4 weeks. Majority of them get better within few days. Thank you for watching.